Good afternoon, everyone. It's just past 12 o'clock, so we'll make a start, but appreciate that other colleagues might join us just as they're grabbing their lunch and joining us for our first webinar for the refreshed Scottish Patient Safety Paediatric programme. Come to the next slide. Thanks, Dagmara. So my name is Jo Thompson. I'm a Senior Improvement Advisor in Healthcare Improvement Scotland, and I'll be your chair for this webinar. I'm supported today by our SPSP team, including Tim and Sonia, who you'll hear from shortly, and Damien and Dagmara. And we're delighted that colleagues from across Healthcare Improvement Scotland are supporting this session. And I'll introduce Sandra, Rachel and Toby as we go through the agenda. Firstly, some housekeeping. Please keep your microphones turned off and your cameras off during the presentation, but we will be encouraging you to turn on your cameras for the Q&A session when we'll remove the slides from the screen so we can see everyone. We'd also encourage you to think of questions for our speakers, and you'll have an opportunity to ask these at the end of all of the talks. So please pop your questions in the chat box or raise your hand when we come to that section of the agenda. We are going to record this webinar so it can be used as a resource on our website after today. So please just let us know if you're not comfortable with this, or if you don't want to ask a question and send it to us afterwards. We'd be happy to answer that for you. And here's our agenda for the next hour and a bit. You'll shortly hear from Tim, who will share some context and information about the SPSP Paediatric programme. Our clinical lead, Sonia Joseph, will then provide a quick overview of the Paediatric Early Warning Score before we hear from Sandra and Rachel, our Excellence in Care colleagues, who will talk about the PEWS in more detail and the measurement that supports it. Toby, our colleague from the Data Measurement and Business Intelligence team, will then talk more about data and measurement for improvement. And after that, it'll be your opportunity to ask the speakers any questions you have. So please keep a note of these as you listen to the presentations. The topic for today's webinar was agreed through feedback from our SPSP Paediatric collaborative teams. And you'll see on the screen there our aims for today. So they are to provide a background on the development of the Paediatric Early Warning Score, provide an understanding of how the PEWS can measure harm caused by deterioration, understand data and measurement for quality improvement, and understand excellence in care in the Scottish Patient Safety Programme measures around the PEWS. So we're really looking forward to engaging with you on this topic, and we hope you find it a helpful session. I'm now going to hand over to Tim, who's an improvement advisor supporting the SPSP Paediatric programme. Tim's going to talk us through a quick icebreaker and then provide an overview of the SPSP Paediatric programme. Thanks. Tim, over to you.
Thank you, Jo. So as Jo said, my name's Tim Shimon and I'm an improvement advisor working on the SPSP Paediatric programme. So a very warm welcome to everybody that's joined us today. I have had a look at the registrations and we've got a very wide selection of people joining us. So I'm just going to launch a poll in the chat and I'd like you to select where you're joining us from today. I completely understand that there may be people from outside the NHS Scotland system, in which case there's a spot for you to select other. And if you do that, I would encourage you to add into the chat where it is that you're joining us from. So I'll give everybody some time to just submit that. Fantastic. Thank you to everybody. And I can see that we've got quite a big selection of people here today from virtually all of the health boards in Scotland. So that's great to see. And we've also got some colleagues joining us from some of the special boards in Scotland, the Scottish Ambulance Service, Education for Scotland. Fantastic. And the Scottish Government colleagues as well. So thank you and welcome to everybody. I'm really pleased that you've joined us today. So I suppose today, I wanted to just start by giving a bit of background to the SPSP Paediatric Collaborative. It's a quality improvement collaborative that it involves 12 of Scotland's 14 territorial health boards that are taking part, and we only launched it 2 months ago in September of this year. The aim of the collaborative is to reduce harm caused by deterioration in children and young people, and our remit's within acute hospitals at present, with the collaborative due to run until March 2025. It's supported by the Paediatric Driver Diagram and Change package, which includes evidence, tools, and resources to support the testing of change ideas, which is available on our website if you scan the QR code there if you're not familiar with it. I'd encourage everybody on the call today to have a look, and regardless of whether you are taking part in the SPSP Paediatric Collaborative, there very well may be something there for you to take away if you have a look at the driver diagram. The next thing I'd like to point out for collaborative team members is our measurement toolkit, which has now been posted in the Teams channel if you're a part of that. It allows you to create run charts of the data that you're collecting for the program in order to monitor for change. And just for everybody else, you'll see, if you can read that finely enough, you'll see that our primary outcome measures are related to successful completion of the PEWS. And this is different from some other outcome measures where you might be looking at an outcome such as a cardiac arrest rate or a number of falls on a ward. And the reason for this is that if we are aiming to reduce harm caused by deterioration, then that harm looks very different for different children in different settings. And Scotland has a wide range of different settings. So in a remote and rural setting, deterioration might lead to emergency transfer out, or in a tertiary hospital setting, deterioration could lead to an unplanned ITU admission. So Scotland-wide, one unifying and measurable way of determining whether or not we are reducing harm caused by deterioration is to monitor how effective we are at detecting deterioration and escalating care, and that's where the PEWS comes in. So what we've done, because we recognise that the system is incredibly busy at present, is we've aligned our measures around the PEWS with the measures collected by Excellence in Care. And this means that any board taking part in the collaborative has to collect data once for both programs. And it means that for us in Healthcare Improvement Scotland, we'll be working closely with our own colleagues who have similar but distinct priorities. And I guess that's why we have guest speakers from Excellence in Care here today to explain the rationale and the meaning of the PEWS measures. This document just here as well, we are also asking teams in the collaborative to submit a narrative progress update so that we can gather qualitative feedback on how the process of improvement is developing, and encourage anybody attending today who's considering doing a quality improvement work to keep a narrative log of your project to keep you on track and enhance your setting. That's whether you're part of our collaborative or you're working on something in your own board yourself. And finally, I just wanted to signpost attendees to some useful resources. So if you get to the end of our webinar today and you feel that you've got more learning to do, these are the places to go. The first resource here is the Essentials of Safe Care, and this is an evidence-based package of tools and resources which can be applied to any clinical setting to help you set up and start a safety-focused quality improvement initiative. So we've used this as the building blocks for our national paediatric program, and if you want to start some work but don't know how to begin, then please have a look at this resource. And the second is the Quality Improvement Zone on PEWS, which is run by NHS Education for Scotland. So if you're an employee of NHS Scotland, you have access to this via PEWS, and the QI Zone provides a range of e-learning modules to help you learn, understand, and implement quality improvement methodology. And it's also a great resource if you want to find out where to take your learning on this topic. So supporting the SPSP Paediatric program will be our learning system. This consists of open webinars such as this one that we're having today, as well as events for members of the SPSP Paediatric Collaborative, such as our 6 monthly learning sessions and our Teams channel. So it's also our role as the SPSP team to collate feedback from boards on our driver diagram and change packages, the tools and resources such as the PEWS that we're using and other supporting resources in the packages, and ideas for future directions for the program. So the feedback that we collate it will be collated, sorry, and recurring themes will note, and we'll note them for future action in collaboration with the clinical community. So I'll now hand over back to Jo for the next session. So thank you.
Thanks, Tim. That was a really helpful whistle-stop tour of our SPSP paediatric programme. Thank you, and some helpful resources there in the chat as well. So now I'm going to pass over to Dr. Sonia Joseph, who's our National Clinical Lead for the SPSP Paediatric Programme. And Sonia is going to give us a very quick overview of PEWS and its origins. So over to you. Thanks, Sonia.
Thanks very much, Joe, and thanks everyone for joining. I hope you can all hear me okay. So this is a fantastic opportunity, and I really appreciate how busy everyone is. So thanks, Dagmar. If you go to the next slide. If we focus on why we're doing this, the work was originally started with Dr. Linda Cleryhugh and Neil Spenceley as clinical leads. And really, it was in response to the Scottish population, primarily the patients that we care for, the staff that rotate between different boards, and the Scottish Ambulance Service, who all said that really we need a common language so that we can all understand how sick the child is in front of us. We need it to go across care interfaces, and we need to be able to empower all grades of staff so that they can communicate their concerns about patients. Hence, the programme was triggered. Next slide. In 2009, there was some early work done looking at the landscape. And then in 2010, the Scottish Paediatric Safety Programme was launched. At that time, there were 5 charts in use across Scotland. And by the time they got to 2012, all boards had some form of early warning score. And what was noted is that there was multiple validated tools, lots of publications around early warning scores in children. And really, there was an understanding that all the teams did lots of the other factors well, such as team huddles, communication. Lots of teams had varying types of escalation scores and systems depending on their clinical environment, which was appropriate. However, what was missing was the common language. Between 2012 and 2015, they started to develop the national PEWS chart using a Delphi process and testing and validation. And in 2015, that's when the shared PEWS chart was launched. And between 2015 and 18, lots of different teams across Scotland adopted the PEWS. And one thing that should be very clear is that the measures that were on the PEWS chart are never altered. It's always just the subsequent paperwork and the escalation that can be altered by different teams to adapt to their healthcare environment, because we all recognise that remote and rural is very different to the tertiary centre that I work in. Between 2020 and 22, the programme went into hibernation, and then we relaunched in 22 and with involvement from all the boards and subsequent ERG, and launched our package in September 2023. And we had the opportunity with Linda Cleryhugh to present at the RCPCH with the development of our driver diagram in spring this year. And it was fantastic to get that feedback and engagement. Next slide. So how did they get the PEWS to where it was to launch in 2015? Well, they reviewed the existing charts. Now, bear in mind, it went from 5 charts in 2010 to every single health board having a chart by 2012. They reviewed all of them, looked at the core content, and recognised that everyone had airway, breathing, and circulation measures. Some had measures around disability, but everyone had a comment on conscious level. But the key thing that was starting to be noted in the literature and from feedback in the health boards was that staff concern and parental concern didn't often have a point in every single chart that was reviewed, but it was something that was recognised that lots of children were escalated for additional and supportive care in other centres where the staff just had a feeling that something wasn't right, but the PEWS scores may necessarily not have reflected physiological changes and parameters. So they went on to study the different scores that were available. Next slide. And the two main systems were a binary system where you were either white or red, or multicolored traffic light systems, and the scoring could go up to 5 for the different parameters. They tested using iterative cycles across different health boards and eventually landed on a 2-color traffic light system, which was then subsequently tested in detail in multiple health boards across 9 areas, and then retested again after a national workshop, and human factors components were rebuilt back into the chart, and the detailed testing was subsequently done in 2 health boards, and then the chart was launched. Next slide. So through these iterative testing processes, repeated cycles of validation, using lots and lots of literature that was coming out at the time internationally, and primarily simulation-based testing in the environments that the teams were working in, they managed to find out and clarify that their new score was as reliable, if not more reliable, in all the inpatient settings that they tested it in. And the subsequent work was felt that with education around the chart and supportive escalation measures that were appropriate to that healthcare system, then you could get it from 75 to 95% accuracy of escalation right up to 95 to 100% accuracy of escalation and identification of deteriorating patient. What I find quite interesting is Neil and Linda and all the literature is very clear that regardless of the parameters on your tools, it's actually about the system of care around the patients. And I'm going to quote from the Pat Brady paper from 2012 from Cincinnati Children's, which was one of the founding sort of papers that was used to launch the different early warning scores. And Pat states, children don't suddenly deteriorate, healthcare staff suddenly notice. And so our change package is very much based around that ability to empower different tools in their healthcare settings to identify and respond to the deteriorating patient. Thank you.
Thanks so much, Sonia. That was a really, really helpful overview of how we've got to where we've got to and the clinical perspective as well. So I'm now going to welcome Rachel Wilson-Lowe and Sandra Ross, who are our colleagues in Healthcare Improvement Scotland and the Excellence in Care team. Rachel and Sandra are going to share more about excellence in care and PEWS. And please just remember to jot down any questions you have as you listen to our speakers, or pop them in the chat box and we'll come to them when we get to our Q&A. Thanks, Rachel. Sandra.
Thank you, Jo, and thanks very much for the opportunity to be part of the webinar today with everyone. I'll be giving a brief overview of the Excellence in Care programme and why it's important before Rachel goes on to talk about the 2 PEWS measures that are submitted into Excellence in Care. Next slide, please. Next slide as well, thanks. So to understand why Excellence in Care, we need to look back at the reasons why it originated. Next slide, please. So the failed leaving inquiry was a result of the C. diff outbreak, which regrettably had a factor or a direct cause in the death of 34 patients. The report that was carried out found that there were systemic failings that contributed to these deaths, and it set out 21 recommendations that looked to improve basic nursing issues. This included the fundamentals of care around compassion, person-centred, communication, either written or verbal, from staff to patient or between staff themselves. Next slide, please. So Excellence in Care was commissioned by Scottish Government as a collaborative national approach with the aim to ensure people have the confidence they will receive a consistent standard of high quality of care no matter where they receive treatment within Scotland. The Bail of Leaving Inquiry families have been crucial in shaping and developing the Excellence in Care vision, and it's a national approach for assurance and improvement using the quality management system, which provides data at a ward and team level as well as hospital, board and national level. Excellence in Care were asked to develop a small suite of measures across nursing and midwifery families that provide evidence of good practice and signal areas for improvement. Next slide, please. So Excellence in Care was one of the programmes that was paused due to the COVID pandemic. This provided the opportunity for us to work alongside our key stakeholders to refresh the foundations of the programme, namely our framework, our strategy and our vision. And although the focus has been on nursing and midwifery, we do recognise that care is provided by a multidisciplinary team, and we're in the process of moving towards this. In essence, Excellence in Care provides assurance and supports the culture to deliver a consistent, high quality care with clear lines of assurance on quality of care. So Excellence in Care is based on the premise that to achieve excellence in care, all of the elements within the framework are interlinked and of equal importance. And at the centre, we can see the four main themes coming out of the Veil of Leaving inquiry, which are our foundations of fundamentals of care, communication, compassion, and person-centred care, which are all delivered within a continuous improvement. And here we see the three elements of quality planning, quality control, and quality improvement. Then moving out from the centre, we have patient safety, supported by the Scottish Patient Safety Programme, care evidence by evidence and standards, and delivered by an enabled workforce, which is appropriately trained, work in sufficient numbers and skill mix. And in this way, we see that excellence in care links with the Common Staffing Method and the Health and Care Staffing Act of 2019. This is all supported by the leadership and culture, which support creating the conditions for continuous quality improvement. Using systems and processes to provide assurance from point of care to board level as part of local governance arrangements that support the opportunities for shared learning. And further details around this can be seen within the Excellence in Care framework, and the link will be shared later in the presentation as well. Next slide, please. Excellence in Care is supported by the Scottish Executive Nurse Directors and by local excellence care clinical leads and e-health leads to provide assurance of quality of care from point of care to board. To help support this, as I mentioned, we have a small suite of measures of quality which have been developed. We have the core measures, which affects all of the nurse and midwifery families, and speciality measures, which are specific to certain services. For example, our PEWS measures, which were created alongside development of the National Care Assurance Improvement Resource Dashboard. This enables clinical staff at all levels of the organisation to view the quality of nursing and midwifery care from a ward or team level to site, board and a Scotland-wide level. Next slide, please. Thank you. Care is not intended as a performance tool, but to help local teams to understand and to own their local data, identifying areas for improvement, and for the staff to use the data to start conversations with their team and to practice shared learning. Care also provides the opportunity to triangulate our measures, so you can look at your workforce data at the same time as you're looking at your PEWS measures to identify any links in the system. Access to care is similar to Discovery, where you need to apply for access, and please feel free to use the link that we'll share as well to apply for access if you don't already have this. And I'll pass over just now to Rachel, who's going to give a little bit more detail around about the PEWS measures.
Hi everyone. So experiencing a little technical difficulties. Unfortunately, no matter how much you plan, never plan for the internet going a little bit haywire. So forgive me, and if you can't hear me or if nothing is working, please just give me a shout, because I'm on my phone and computer, so it's a bit all over the place. So basically a little kind of, I'm just going to talk through the early warning score systems more broadly before going into the Scottish PEWS and then into the measures that we have on the care dashboard, specifically relating to the pediatric early warning scores. So early warning scores more broadly are system using several physiological indicators, as we've seen, to identify there's a early warning score, but there's also different early warning score systems for different populations out with pediatrics, including maternity.
Rachel, your sound is a little bit bitty. I wonder if
Which uses PEWS, and there's also a Scottish national version. Yeah.
Rachel, I wonder if you
Is
want
it a
to
little bit
turn
better
off,
if I'm like this?
yeah, or turn your video off. It might help your sound. Could try
Okay,
that.
I'll do that. Sorry, everybody, technical difficulties. Hopefully this is a wee bit better. Also, there is the adult early warning score system, which there is the UK-wide News 2 scores that should be used. And it's recommended for use in Scotland to replace local guidelines so that there's a bit more consistency whilst also still being cognizant of the different ways care is delivered across different settings, such as rural settings versus kind of urban settings might be very different. And the indicators measured can include a range of different indicators. It can vary widely depending on who developed them, what population they're for, the age of the population. And here's just a few listed there as well. Next slide, please. So although childhood mortality is infrequent, the UK and unfortunately Scotland in particular does have high rates compared to the rest of Europe. And as Sonia said, children's deaths are, or I should say deterioration doesn't just happen, it's when staff notice deterioration. And thus approximately 50% of in-hospital deaths of children are thought to be avoidable. And the use of having a kind of standardized PEWS aims to reduce this. And in the past 2 decades, more broadly, use of PEWS have risen significantly, within the UK more widely, the data indicating that the rate of PEWS usage has increased from 21.5% in 2005 to 100% in 2018. Obviously not specifying which PEWS they were using in that study, but just generally the use of PEWS has gone up. Next slide, please. So in regards to the development and the variety of different PEWS systems, it can be quite complex due to the vast physiological differences between the ages of 0 to 18 that we're trying to account for. Whereas in adult populations, there's obviously, whilst it's 18 and plus, there's less physiological changes in that developmental period. Children also tend to compensate physiologically, just biologically, making it difficult to detect deterioration in comparison to adult populations. Children also may not be able to communicate as effectively as adults depending on their age, and thus, you're not able to rely on them indicating something is maybe not feeling right in quite the same way as you would with adult populations. And then children generally have lower morbidity and mortality rates than adults, so sometimes it can be difficult to analyze the effectiveness of these different systems as well. Next slide, please. So as I said, many different PEWS have been developed. One literature review found that over 18 unique different systems. And within these different systems, there was a range of 47 different physiological indicators, parameters that were used. Most systems have a range of between 5 to 14 indicators, but this can be as much as 19. But obviously, when developing a PEWS system, you have to take into account the added benefit of adding a new physiological indicator onto the list in comparison to the feasibility and how easy is it then for healthcare staff to gather these physiological indicators and make the correct care decision based off of these indications. Next slide, please. So as I said, the physiological indicators vary quite significantly across different PEWS. But there are some kind of commonalities. So heart rate and respiratory rate were in not over, I suppose, in all of the different PEWS systems that were reviewed. But then you can go down the line in terms of oxygen saturation, there's slightly less usage, blood pressure, slightly less usage, temperature, only 39% take this into account. And it really just depends on the PEWS system you're looking at and how it was developed and ratified in regards to validation. Next slide, please. So oftentimes in a review of these different systems, there's not a specificity in regards to what constitutes quote unquote normal values and relies on clinicians' judgment, which can limit the standardization of the use of this system. And it makes it difficult to compare across different PEWS, and thus a comparison across different hospitals and boards even more difficult. there is also variation in terms of the different age brackets that are used in different PEWS systems. So for some, they might have a specific age bracket of neonatal period, so 0 to 28 days, whereas Scottish PEWS is 0 to 1. So it just really depends on which PEWS system you're looking at there. Next slide, please. So PEWS Scotland, here is the slide that Sonia referred to earlier. These are the various physiological dimensions that are included in PEWS Scotland, and the inclusion and prioritization of having staff and care concern is quite a new, wouldn't say new, but a trend in the development and validation of PEWS, because we're recognizing that it is needed, particularly given children's communication difficulties. So it's really high priority that is there, and allows also some clinical and professional judgment to influence how care escalation is decided. Next slide, please. So there isn't a specific neonatal chart for PEWS Scotland. As I said, it is 0 to 1, but there is space. One unique feature of PEWS Scotland is that on the charts themselves, there is space to create individualized PEWS ranges for those with chronic conditions. So for instance, people with some pulmonary conditions might have a different oxygen saturation level that is normal for them, whereas it might be indicative of somebody, a child deteriorating who didn't have those pulmonary issues. So in this way, the PEWS Scotland is actually very inclusive of those with chronic illnesses or conditions, and is better suited to their needs than those that don't kind of allow for this natural variation amongst the population. Next slide, please. There isn't a baseline frequency of observations recommended in PEWS Scotland, however, there is frequency guidance available for elevated scores. So if you have a score of 1 to 2, you should be repeating observations every 60 minutes, 3 to 4, or any single value in the red zone. So if that one physiological indicator is particularly high, then it would review in 15 minutes and repeat observations every 30 minutes or continuous monitoring, and 5+ demands an immediate review, and for nurses to consider calling a rapid response team. So that's where kind of the guidance and escalation comes in. Next slide, please. So for the current measures that are on the care dashboard for the Excellence in Care program, we have PEWS compliance, which is defined as the percentage compliance with PEWS bundle. So we require all 3 things to be correct. We have to have correct age-related chart. So obviously, if a child is 3, but then they're filling in the 0 to 1 chart, that doesn't work. The correct observations have to be completed, so making sure all the physiological indications are accounted for, and then correct scoring of the chart. So that's more applicable for those that don't have an electronic system to kind of tally it up for them, but just obviously making sure that everything is added up correctly. It doesn't specify in PEWS Scotland in our measure, though it is recommended, because we recognize that everybody is actually using PEWS Scotland now. However, in accordance with other Excellence in Care measures relating to early warning score systems, there has been some variation. So we wanted to make sure we were kind of in line with the other measure documents we have. And we also specify that the neonates that are admitted to pediatric settings rather than a neonatal setting should be included within this measure. However, it should be that a PEWS is used rather than a neonatal specific early warning score system, given that Scottish PEWS doesn't have a 0 to 28 days, rather it has a 0 to 1 age bracket. Next slide, please. So in regards to sampling, so we advise that you select 5 children in a ward, children or young people, I should say, per week, or 20 per month who have a PEWS chart. And for those boards or wards that have slightly smaller populations, if less than 5 per week, please include all. And then if electronic systems are used and we're not requiring kind of manual data collection, we would advise that all patients be included each month if possible. Next slide, please. And so our second measure in related in relation to PEWS is PEWS escalation. So it's the percentage of at-risk observations that are identified, that are acted upon and have appropriate interventions undertaken in terms of their management as identified by the Paediatric Early Warning Score System. So again, PEWS Scotland isn't specified and neonates are included, as I said, with the previous measure. And national guidance is available for ages 12 months and up. So in regards to frequency and how that should be escalated depending on the PEWS score. But for children 11 months and under, we recognize that there isn't there isn't national policy in regards to frequency, so we advise that local policy should be followed. And again, the sampling method is the same as PEWS compliance. Next slide, please. So in regards to our key points in relation to excellence in care. So excellence in care is a national approach to assurance and improvement and encourages kind of standardization so that we can compare across settings and also share learning from what's working really well and in good practice. We support workplace culture to deliver high quality person-centered care. And the care dashboard provides access to local ward level data that then can be triangulated with other relevant measures such as workforce and then be compared at the local level all the way up to board and national level to again trying to see areas of best practice and opportunities for shared learning. Then there's a small suite of standardized measures used across Scotland to identify areas of improvement and share learning at the local and national level, two of which are related specifically to PEWS, PEWS compliance and PEWS escalation. Next slide, please. I think that's it. There we go. I'll pass along.
Thanks so much, Rachel and Sandra, and well done, Rachel, for battling through your technical challenges there. We managed to hear all of what you said there, so that was really helpful. Appreciate that's lots of information for everybody. So again, just reminding you to please jot down questions, pop them in the chat box, and we'll come to them after our final speaker this afternoon, who's Toby Steed. And Toby is a data and measurement advisor in the Data Measurement and Business Intelligence team here at Healthcare Improvement Scotland, and he provides crucial input into all of our safety programmes. Toby is going to talk to us about measurement for improvement. So over to you. Thanks, Toby.
Thanks, Jo. Yeah, as Jo said, I'm a data and measurement advisor, and I work across a lot of different Healthcare Improvement Scotland teams, helping them with the measurement component of the improvement projects, because as we know, measurement and data are a very important part of improvement projects. I'm going to talk to you a little bit today about how measurement sort of can be, how it engages with the improvement project. And then I'm going to spend a little bit of time talking specifically about the SPSP Paediatrics measures, just so maybe you can get a bit inspired to start looking at your PEWS data and things like that. So without further ado, so why do we measure? I mean, the main reason to measure is to take action based off of what you're seeing. Data by itself doesn't do anything, but what we need to do is take data, turn it into information, and then we can start to generate some ideas. But it's only really when we take the actions based off of those ideas that the data actually becomes useful. So measurement is the way that we organize and structure the collection and presentation of data. It takes us up to the information bit, and from there we can sort of start to generate some ideas and take some action. It also helps us to communicate about the state of our system. So by agreeing on a set of measures that tell a story about a system, we can sort of work together to generate ideas and take actions. We can also communicate with others in the wider system about our improvement journey. So the changes we tested and whether they worked. It's really good if you can communicate with colleagues about, we tried this, it worked because X, Y, and Z, so that they can understand whether it might work in their context. But it could also be, say, leadership within your organization to get support for further changes. If you can back up your ideas and your actions with evidence in the form of data, then that turns into a really powerful argument and helps you to achieve your goals. Measurement needs to be based around our theory of change, and that's described in this case in our driver diagram. Measurement should tell us whether we're moving towards our aim, and whether we're doing the things that our theory of change says, we need to get this stuff right. It'll be able to tell us whether we're actually doing those things. So what we're actually doing when we measure is we're testing our theory of change. We're introducing change ideas. We're seeing if they work. We're sort of seeing, does this theory of change hold up? And if it does, great. If it doesn't, maybe it needs a rethink, maybe, that kind of stuff. So when we test our theory of change with these change ideas, we can end up with 3 different results, right? The first one is that our measure improves. We strike gold. We thought that this would be a good thing to do. We tested the change, and it turned out that it was a good thing to do. Great. The second thing that could happen is that nothing happens. The measure that we're interested in moving doesn't move. A tumbleweed just blows through. And then the third potential outcome is that the measure actually gets worse. The thing that we don't want to happen happens. Now, obviously, we want to see the first result every time. That's why we test these ideas. But it's really important to try to understand every result, in particular when things get worse, for a number of reasons. One is you want to understand why it didn't work and maybe change up the strategy. And it's also important to be able to communicate with others. We tried this and it actually went the opposite way. So, like I said, we really want the first result every time, but just because a bad result happened, that doesn't mean it's not useful information. We should be trying to extract useful information out of all the things we do. So those 3 results that I talked about, things getting better, nothing happening, things staying the same, those are why we use run charts a lot in improvement. In my job, pretty much most of what I do is using run charts. And the reason is that run charts give those 3 results for every measure. They will give you those: went up, stayed the same, went down. And it also gives you that information in relatively real time. You can, as long as the run chart's being kept up to date with new information, it will tell you when things are moving once they start moving. So having that information in real time can be a really powerful part of the improvement project. It means you can respond in real time as well. So run charts are bread and butter part of improvement work. Also, Tim mentioned the data collection toolkit that we provide as part of SPSP Paediatrics. Those will actually build the run charts for you. So I'm not going to talk in detail about run chart rules. They're a bit in depth, but I will say that the toolkits that we provide actually build them for you. So all you need to do is put your data in, and you will get a run chart out the other side that you can start to annotate, tell your improvement story with, and respond to the results and take actions. Okay, so measurement sort of strategy. So to fully understand how our improvement project is progressing, we need a family of measures. And those are outcome measures, process measures, and balancing measures. And what these do is they help to make sure that the measurement strategy is directed fully at the actual theory of change. They help you to align the 2, so that they're working together and you're getting the most out of your data. So The outcome measures, those tell us progress against our aim. Now, improving the outcome measure may take some time. These are the slowest to change often, and it's important that these outcome measures are measured in the same way. So if a lot of people are collaborating on an improvement project, it's really important that they all have the same definitions for their outcome measure, that the data is collected in the same way, so that they can have these conversations about what's happening and what's working and what's not working. Our process measures, these tell a team whether a specific process is happening reliably. So when we looked back at our theory of change, in our driver diagram, there were some primary drivers and some secondary drivers. Those are the things that we say we need to get these right every time in order to have a decent chance of affecting the outcome and achieving the aim. We need to get this stuff right. And that's what a process measure tells you, is are we getting this right reliably? Are we doing the things that we say we need to do in order to get to that aim? So you can direct process measures at your drivers. You could also set up a sort of temporary process measures for tests of change that you're running. So specifically related to this one change, you could set up a process measure that's just making sure that test of change is happening reliably, so that and then discontinue it once you're done with it. You know, some are a bit more permanent and will last the length of the improvement project. Some can just be set up on a temporary basis. You know, we don't want to make a massive burden of collecting all this data and analyzing it. We want to be able to use it and then move on if we don't need it anymore. Balancing measures are probably the trickiest part. They help us to check for other issues of quality that might arise as a result of our change ideas. So one example is looking at maybe, say, waiting times. If we're working on a project that the main outcome isn't related to waiting times, we might end up using up a lot of capacity to introducing all these tests of change, and that results in us not being able to see as many patients, and as a result the waits go up. So one thing I tried to think about with the balancing measures is looking at other areas of quality that are separate to the actual one that our aim is related to, and that helps us to round out our improvement project and make sure that it's not sort of not got tunnel vision on the outcome of interest. One thing to note, if the balancing measure gets worse, doesn't mean that we should abandon the change if it's working, but we should again seek to understand, maybe take some action to mitigate the unintended consequences. You know, this is all about understanding the system, responding to it in sort of on a continuous basis. Yeah. Okay. So I'm going to talk a little bit now about the SPSP pediatric measures. So you can see here on the left the aim. The aim is to reduce harm from deterioration by improving the recognition, response, and review of the deteriorating child and young person. And now the team has decided to focus on getting these PEWS measures, these observations and escalation processes right every time. So really working on making sure that the PEWS processes are spot on. So all of the measures here are related to getting towards that aim. So the first one is use of the correct age-related chart. This is fairly self-explanatory, but it's a really important one to get right off the bat. And it's one where it might be that some fairly quick wins exist on this one. If we do our case note reviews and we find that we're at 60-70% for the correct age-related charts, understanding why that is could have some quite quick answers. Maybe there's an inventory check needed in the stock cupboard because there aren't enough printed out of the right one. This should be a straightforward one to get very reliable every time. But we do need to be assured that it is reliably happening every time, so that we can start to look at the other measures, because it's no good calculating the right score on the wrong chart. So this is one that it's in there and it's important to get right, and it should be probably the first one to make sure that we're really reliable on. So reliable use of PEWS observations. So this one looks at whether the observations are being taken correctly at the right intervals. And those, I can't remember if those are standard or based on local policy. But there's an important concept I wanted to get across with this one. These sort of measurement in QI, a lot of it comes from operations management, working in factories and things like that. And if we think about plates coming out of a conveyor belt, coming out of a factory, the number of breaks in a plate isn't the really important first thing to get right. It's important to make sure that the plate isn't broken. So this is an important concept of number of flaws versus is it flawed or not. And with this first reliable use of PEWS observations measure, what we're really focusing on is whether it's flawed or not. So if there is any fault in the observations in that chart that's being reviewed, then that should go down as this PEWS chart didn't pass this test. It is flawed. Now, that's not the end of looking at this measure. If as part of the review of the case notes, it turns out that there's a bit of a pattern emerging, so the blood pressure is the one that it's always failing on, then you can start to run some extra measures, maybe looking at just the blood pressure element of the chart, and also some tests of change just to focus on particular elements of it. But as a headline outcome measure, is it flawed or not is the important first one to check. And then after that, delving into the actual detail of it. So I guess this brings up another important element, which is this isn't the end of the measurement, but getting these measures in isn't the end of the story. It's actually only the beginning. It should give you the information to then take things further, right? So setting up a little process measure on individual elements might be a really important part of getting this measure right. Reliable scoring of PEWS. This is another one that has the flawed versus number of flaws idea in it. And again, we're interested at the headline level on whether it's flawed or not, and not how many flaws are involved in it. Local improvement projects directed by what's actually happening as part of the flaws are where you start to look more in detail at what the actual flaws are. But the measure that should be the headline outcome measure is the plate broken or not. Important to note that there's a bunch of different ways that reliable scoring can go wrong. So either the wrong score is applied in the chart itself, or it's added up wrong. So it could be an arithmetic problem, or it could be it could be a problem with the actual assigning of scores to different levels. So a few different things to check there, and those could occur at any point in the chart. So whether that's temperature or respiratory rate. So again, figuring out whether we're at 60% or 90% is important. before then looking at individual elements of it and saying, well, are we getting heart rate right every time? And that will come as part of the work involved in actually going into the case notes and checking that this is being done correctly. And that does require a fair amount of experience and understanding of PEWS. So, you know, this is useful work. Just collecting this data can help you to understand your system a lot better just by doing this. Reliable response to PEWS trigger is the last one. Oh, some of the observant among you might have noticed that the previous three all bound together in a nothing about this is flawed. That is a reflection of the excellence in care measure for PEWS compliance. Those should be the same thing. Those should add up together to make one. And then the PEWS escalation is the corollary of this one. Reliable response to PEWS trigger. I think one thing I wanted to note here is that with the previous three, the population that you're drawing from is the number of people, number of patients with a PEWS chart. Whereas for this one, the actual population that's being drawn from, i.e. the denominator, is the number of people who had an escalation event. So these are slightly, they're the same sampling method. You're looking at 5 charts a week, but they're a different population. You're only looking at the ones that have actually had an escalation event, and checking whether the escalation is reliable. But like I said, this checks that the response to PEWS proceeded in line with local policy. So again, it's going to be really hard to figure out. It's going to be quite difficult to measure which elements of that aren't going right, and I think that's why having an experienced person reviewing these charts is going to be really important for getting getting the learning out of this measure, because measurement's quite a blunt tool when we're talking about quantitative measurement. The qualitative stuff is where the why really is, and so having someone with a depth of experience looking through these charts and making will be really invaluable in figuring out why we're on 70% reliable response to PEWS trigger rather than 90 where we want to be, 95. So that's one thing I wanted to say about this one. There's a few questions in the chat, but we're going to have a little bit of time at the end, so we can deal with them then, but I have spotted that one. Okay, so I'll sum up now. Remember, we shouldn't just measure. We should measure with the intention of doing something. So for every measure that we introduce to our project, we really should have a decent idea and a decent plan for, it doesn't have to be a specific plan, but it does need to be something that we're going to take action based off the back of. We shouldn't add to the data burden without making sure that we're extracting some value from it. And then lastly, use measurement as an aid to your improvement journey. This is a great diagram illustration by Katrina Hayes. I think she's still at the Scottish Government, at least she was when I did some work with them. So the improvement journey is a long one, but data is really useful at every step. Understanding your system, developing your aim, testing your changes, spreading and sharing. Data is really useful at every step for those reasons that I outlined at the start. It's great as a communication tool, and it's great as a prompt for action. I think that's everything from me, so I'll pass back now.
Thank you so much, Toby, and to all of our speakers this afternoon. I've certainly learned lots of new things, and I hope that you found them interesting too. So thanks to Tim, Sonia, Rachel, Sandra and Toby. So now it's your chance to ask any questions you have for our speakers. We're going to take the slides down and please feel free to turn your camera on so we can see people who are on the call and see who's asking a question. Just raise your hand if you have any questions, or put them in the chat box, and Tim is going to help me out by monitoring the chat box. And Tim, I think I'll come to you first because I have seen a bit of chat in there, for you to go through the questions first that are in the chat box, and then we'll come to any hands that are raised. Thanks.
Brilliant. Thanks, Jo. So there have been a few questions come through, some of which Sonia's put in some responses to as well. So I'll just summarise those quickly. The first one was about whether or not there's been any pre-hospital validation for the PEWS done, and Sonia's posted a response there with some links to some of the pre-hospital work that has been done and is actually ongoing. There was another question from Una about the consideration of different types of skin color in relation to saturation measurements. And again, that's certainly something that's come up in the literature during COVID quite significantly, and also more recently. I think Sonia's posted a response to that as well, and for the SPSP Paediatrics program, that certainly formed part of our consideration in our qualities impact assessment as well. So it's been considered. I think probably perhaps what's lacking there is some guidance from some resources and tools on how to manage that. But I think Sonia's popped in the response to that in the chat. Secondly is a question from Una as well about including a posture reminder in the airway assessment for children with communication disabilities, and this might be included in the individualized PEWS chart, but we might need to link to any communication passport. So is it already available to staff? So that was the first question about considering, I guess, the postural needs when assessing a child with the PEWS, and I suppose I probably have some response to that myself, Una, in that in our SPSP Paediatric driver diagram and change package, we've included resources from PEWS, which I think actually you suggested to us. So we've included some resources from PEWS and a few other resources there on ensuring that that posture is kept at the forefront of people's minds when they're assessing children, because it can lead, obviously, as you said, it could lead to some fairly erroneous assessments if you're not considering the child's normal posture. So that's definitely a very good point, well raised. And the final question to come to in the chat box is, do any areas use a randomization method for deciding which 5 charts to pull to audit? So I'll open that up. I'm not sure if somebody from Excellence in Care knows.
Sandra, do you want to? I think you'd probably be the best place to answer that.
It's certainly not come up in conversation about how they choose the charts. I think just in our measure, for the escalation one, it's the ones which were identified as high risk. I think that's the way that they pick the ones when they look at for those charts, but not for the general compliance. I think it's just random however they choose it. And if there's more than if they're able to extract the information digitally, then I think it's everyone is included rather than just a random sample size.
Thanks, Sandra. I see, Claire, you've got your hand up. I don't know if you want to come in, and then if Toby has anything to add.
And I'm not going to speak from a paediatric point of view, but I'm just going to speak from a randomisation point of view, that I think local teams develop their own methods. So I know of teams who do the last 5 admissions, or they rotate the bays or the rooms in an area so that they're not seeing the same. So 1 month they'll do rooms 1 to 5, next month they'll do 6 to. So I think it's up for local teams to decide what they're doing, but just I suppose stay away from choosing ones that you think just might be correct, because as Toby quite rightly said, most of this is in the learning, isn't it? So yeah, I think it's just for local teams to come up with that plan.
Thanks, Claire. Anything else to add, Toby?
Yeah, just to add to that, I mean, as a scientist, and I would always advocate for being as random as possible, but I also think in this case, as Claire said, the really important stuff is in the learning, and what we're not trying to do is conduct a randomized controlled trial of whether PEWS works. What we're trying to do is improve the system and make sure that we can get this right as much as possible. So you know, there's one real conflict in a lot of these scores where, say you've got the wrong chart, do you mark the score, as it were, for the right patient wrong chart, or wrong patient right chart, you know, or wrong score for right patient? That there's a lot of ways that it can go wrong, but I think that it doesn't matter so much as long as what we're doing is extracting that learning from the review of the charts and implementing those changes that should get us to a better place. Then the sampling method can be as pragmatic as you need it to be, rather than being strictly scientific.
Thanks, Toby. I see, Una, you've got your hand up if you wanted to come back in.
Yeah, thanks very much. I'm just really interested in the section on the patient or carer concern box, and just how are patients and carers advised about how to get best use of that, or are staff expected to invite comments when they do the observations, or do they wait for the patient to raise the concern? It's just something, it's so important, and I think sometimes we don't take full advantage of that opportunity, especially this thing with Martha's rule coming in, where it could be over-interpreted, I think, in some cases. Thanks.
Great question, thanks, Una. And as I think it was Rachel said, it is very prominent in the literature and in a lot of the work that we've done in this work and in other work as well around that patient family concern and how that's captured specifically, as well as staff concern. I'll maybe go to Sonia first, and then Rachel, if you want to add anything too.
Hi, thanks, Una. So essentially for different boards, a lot of them are implementing patient-centered care questionnaires into their electronic systems. So as part of it, there's the did you eat, did you drink, and do you have any concerns? We're doing a piece of work locally to find out what are the questions that the nursing team are asking proactively. How are they framing it for different age groups? And the other thing is that for when we've had patients transferred to HDU, we're looking at the charts and saying, did they, what did track say versus did the team use the yes, no concerns box on the PEWS? And I think we do. The general feeling is we could probably improve on that and give a kind of set of very simple questions that staff feel enabled to ask, because often it's you might have a band 5 who's done it for years, so they very naturally ask questions that are open and give families the opportunity to raise concerns, whilst a brand new band 5 might feel a bit cautious around asking specific questions. So we're trying to give people the tools that the senior automatically does, so the junior just knows it. And if you ask these 3 questions, you will get a lot more out of the patients and families. The other thing is what are the best questions to ask young adolescents? Because certainly after the age of 12, most of the children and even actually 10-year-olds will be able to tell you more accurately if you feel not right. Often in the ward round, I'll take the mickey out of myself being a middle-aged lady and saying, do you feel better? And for younger kids, is it better, about the same, is it worse? There's lots you can do, but how do you structure that in a way so that happens every time? And that's still a work in progress, I would say. And most of the boards that we went through, in fact, all the boards that we went to, none of them felt that they had that cracked. They felt that everybody had the intention was there, but could they consistently say that every single family and child felt able to ask for help or raise concerns in a structured way? Nobody felt like they had that cracked. And I think the final thing I would say is, in New Zealand, what I was really impressed with is that they have this code pink policy, and that is plastered in every single room in the ED. And it's if the families feel that they have concern and they're not being listened to, there's an actual telephone number that families can dial, and it takes them to the most senior nurse that's running the building, and there's an automatic response expected from that nurse where they'll come down, and they're a nurse with advanced skills who also has coordination and managerial responsibilities for the building on shift that time. There were the initial concerns that you know, would families use it inappropriately? Would there be lots of inappropriate calls, etc.? But what they found is that there's only been 3 inappropriate calls in a year. And actually, it was important that the nurse went to that situation because it was more an escalating emotional situation rather than a deteriorating child. But the nurse was able to contain the emotion and deal with the emotion from the family so that the care could be delivered to the child appropriately. And in all the other cases that frequently the children ended up needing some form of escalation. Either they got IV antibiotics when they got senior assessment, or they ended up going to high dependency and critical care. So that's something that Tim and I have linked with the team in New Zealand, and we're quite keen to see how they develop that and what we could potentially do with that to empower our local teams across Scotland. Thanks.
Thanks, Sonia. You and Tim
Thank
have
you.
obviously been working together for far too long now, because just as you mentioned that, he popped the link in the chat box, so perfect. Rachel, did you want to come in on that as well, because you'd had your hand up before?
Yeah, just very, very briefly as well. This aspect of also, of course, my camera and everything's working after I'm presenting, but oh well. In relation to the equality and impact assessments, it did come up in. I think I'd say there's more literature specifically for maternity early warning scores, and that patient concern rather than directly coming from the pediatric setting. But there are some kind of indications that unfortunately patient concern or care concern is not necessarily taken as seriously depending on some of the protected characteristics of that patient or their carers. So I think there's work, you know, or to be cognizant of some of those kind of implicit biases, perhaps based off of ethnicity or socioeconomic status, that might impact how that concern is being taken into consideration. But that's, you know, something that we maybe need to have some guidance on, just being, you know, aware of those biases in regards to taking account of that concern from those people.
Thanks, Rachel.
Joe,
just
can I just, Joe, sorry, just I'm on that point. I don't know if Jonathan Bamber from the RCPCH is still on the call. It looks like he is. I don't know if Jonathan, is there a, hi? I don't know if there's any comment from a college perspective on that in terms of patient and family opinion, or anything you'd like to bring in from your linkage work with the English PEWS or anything? Sorry to drop you in it.
No, it's absolutely fine. And thank you everyone for a fantastic presentation of some really interesting work. On the child and parental concern side, the NHS England programme is trying to tackle similar problems. So be it something along the line of COPINC or equivalent. I think the only aspect I would say is that it's what you do once there is a response is something that I know within the recently launched English PEWS, they recognise that they haven't got that cracked, and that is another aspect of change which would be really interesting as part of this improvement program, if it can be looked into, and what variation there is in because it doesn't matter if you're responding to parental concern if you're not responding in the appropriate way. So that's the other aspect which I'd throw in there. But it's clearly something of distinguishing between the having parents and children having concerns which need to be looked into, and looking into perceived harm and restorative justice, which has a little bit more time associated with it, and the immediate need to, if there is someone flagging that there is deterioration that is not being picked up. And there might be something there around teasing the distinction between the two, which I know as part of the recent response to Martha's rule that the NHS England team are looking into, and it's something the RCPCH is really keen to tease out, when there are differences between that immediate action needed to be taken with a deterioration and the importance of recognising when people have concerns about the care they're given.
Great, thank you so much.
Thanks, Jonathan, and great to have you on the call as well. So we're keen to learn from others in the UK and share where we're at as well. So thanks for joining us.
Yeah, vice versa.
Emma, you've been waiting patiently with your hand up, so I'll come to you now for your question.
Oh, not a problem. Thank you. Really interesting to hear all the speakers today, and thank you so much. I've got quite a specific question around the audit of the PEWS chart and the components of audit that give us our total score. We see in news and MEWS that every parameter has to be completed to give us our total score for audit and our total compliance. But obviously with paediatric patients, blood pressure can be a bit of a variable component. And I was just wondering, is there guidance around what we should be expecting or how to audit that? Because we do want to give the most accurate data in the fairest way. And I know that not every child needs their blood pressure done every time, but I just wondered if there was any guidance for boards around that.
Thanks, Emma. And it is something that we've talked about as a team. I'll maybe just pass over to Sonia in the first instance to answer your question.
So I think there's lots of discussion around it currently, and the reason is because there's recognition of variation in practice. So even in my own hospital, which is a tertiary and for some specialties quaternary centre, I know that in haematology oncology ward, every child will get a blood pressure every time, and the children are just used to having it. Whilst in the acute receiving unit, you will get a blood pressure on the first two measurements, and as a minimum, and certainly within 24 hours of admission, if you are stable, well, and your PEWS has continued to improve, then you won't get any, you'll either get no further blood pressure measurements because you're running around in the playroom and very well, or you might get a once a day blood pressure unless there's a specific instruction to then initiate blood pressures again. We've also recently audited it as part of pre-audit work for the national engagement. And what we've recognised is that every time a child there's been concerns about a child, I like to call it nay right. If there's a feeling from the parent or their staff that there's something not right, then frequently the staff will automatically initiate blood pressure measurements and go along the escalation scale, as well as a blood glucose, which I think is important, especially in young children. But what we don't have is a local derogation policy that has adapted to the new site. So we've got one from our old hospital site, but we moved in March 21. And so what we're looking for is revisiting that derogation policy, because the ward alignments are different and some of the patient populations are different. So what we want to do is improve our reliability when we know the children are sick. So therefore they should absolutely have their blood pressure measured. But what we don't have, and we haven't quite fully cracked, is when the children are now much better, do you just accept that you do that once daily blood pressure and that's a completely reliable PEWS set and score, and the rest of it is you have a written derogation in the notes, whichever way you do your notes, paper or track, to say these are the reasons why we didn't keep measuring blood pressure, i.e. they're well. So nobody's quite cracked it, but what it says in the driver diagram and change packages that we need to make sure that there's local policies and local ways of deciding when you're going to do a blood pressure or not. Because certainly when we spoke to the Western Isles team and the team in Shetland, they were saying yes, they can do a blood pressure, but how often do they do it in children? And so it's trying to find what's the local derogation and the reasons why. So we haven't quite cracked it yet, but it is definitely part of the discussions we'll be having going forward, and probably comparing the events that are happening within each team. When we're doing the local data collection, we can compare different units and feedback and use it as part of a way to have active discussion, if that makes sense.
Thanks, Sonia. I see Claire's popped a comment in the chat as well. I'll come to you, Claire, and then we'll just try and wrap up soon, I think. Claire,
Yeah,
did you want to add anything?
so I guess what I've just put in the chat is there evidence of decision making with the exclusion criteria locally? So, if you audit a set of observations and someone hasn't had a blood pressure, does it marry up with the fact that there's been a decision made that that's not to happen, and that's documented wherever the local policy is to document that? So I guess it's not for us as a sort of national improvement organisation to decide clinical decisions for people, but it is is that an omission from the observations, or is that care as planned?
Thanks, Claire. I'll just pop to Tim, just see if there's any final questions in the chat box for us to answer. I think a few of them have perhaps been answered by others on the webinar, which is always really helpful and nice to see the community supporting each other and making those connections already. But is there anything, Tim, that's outstanding for us?
So I think the main questions that have popped up have been around the use of EOBS or electronic PEWS. And I think, yeah, as you said, a lot of people have made links and connections in today's webinars to help each other out. So that's great to see. And I suppose it's certainly, Claire will probably back me up on this, compared to the adult world, electronic observations and EOBS in the pediatrics world are not as far along as they are in adults. So there's probably some learning as we move forward to take from the adult program that's doing this at the same time. So I attend a lot of the adult deteriorating patient network meetings, and I'm keeping a note of what comes up in those regarding EOBS, because the more boards that are coming online in pediatrics with the EOBS, the more that we can sort of facilitate our own network to share that learning and disseminate what adults have learned.
Great, thank you, Tim. So that's just bringing us to the close of the Q&A session. So we're just going to wrap up with a few final slides before we let you carry on with your afternoon. So whilst those are just getting popped up, just to say that we really do value your feedback from all of these sessions that we run and all of our events. So we would be very grateful if you could just take a couple of minutes to answer a few questions on our evaluation form. You can scan the QR code that is on the screen now. And as I mentioned at the start of this webinar, the topic for today was agreed on after we'd consulted our SPSP collaborative teams. So we are keen to host future webinars on areas that will support your quality improvement efforts in relation to the SPSP paediatric programme, and we can only do that if you tell us what those priorities are. So please do give us your feedback, and we really appreciate that. So on the next slide is just our call to action. Thanks, Sagmara. So that evaluation link is the same one. It's still there if you haven't had the chance to fill in the form yet and get your phone out. So in closing, we just wanted to share some actions that you can do today, tomorrow, this week with your teams. And we appreciate we have shared a lot of information with you in the last hour or so. So you can visit the QI zone on Chiras. As has been mentioned, this has got a wealth of resources to support your QI work, and there's a link in the chat box being shared. You can register for the care dashboard that Sandra and Rachel showed us. Again, a link has been shared for you to register, and your password for that would be the same as one that you use for Discovery if you access Discovery. And training is also available to support you in using this. You can familiarise yourself with the SPSP paediatric driver diagram. Another link going in the chat box for this driver diagram, which is a resource, as Tim outlined, that supports teams to improve that recognition, response and review of the deteriorating child and young person. It brings together what is known about best practice, processes, and it's based on the literature, research, and the co-design and input from you and others in the paediatric community. You can review your PEWS process with your team. So do you understand your system? Is everyone in your team engaged and aware of your PEWS process? What data do you have, qualitative and quantitative, that can support you in that? And you can link with a local Excellence in Care and Scottish Patient Safety Programme lead in your board. There are Excellence in Care and SPSP leads in every board who can support you and share further information with you. So please seek them out. And if you don't know who your contacts are in your boards, please contact us and we can help you with that. So finally, just please keep in touch with us if you want any more information about anything you've heard today, or if you have any questions once you've reflected on the webinar today. We're happy to help where we can, and really appreciate you joining us this afternoon. So it just leaves me to say thank you to all of our speakers. Thank you for joining us and for all of your questions and for answering some of the questions too. And we hope to see you at a future webinar. Thank you.